Hi, I'm David Liska. I'm a colorectal surgeon at the Cleveland Clinic, and I'll be talking to you today about preoperative risk stratification and enhanced recovery after surgery. I have no relevant disclosures. Just as an outline, I'll start off by talking about preoperative risk stratification, some screening, then specifically some details about cardiac risk stratification, some other predictive risk scores, and then a management algorithm. And then I'll move on to the bulk of the talk, which will be about enhanced recovery after surgery or enhanced recovery protocols. And that really encompasses the entire perioperative care phase, including preoperative phase, the preparation and the day of surgery, intraop, and then postoperative care as well. So starting with preoperative risk stratification, it is important to keep in mind what the goal of this is. And the goal of preoperative evaluation is to detect any potential unrecognized conditions and risk factors that may increase the risk of surgery, with the ultimate goal being that if there is such a risk, then propose strategies that can reduce these risks. And not everybody needs a complete workup and extensive testing, and there's multiple different screening tools available and screening questionnaires, and that's something we here use routinely, and our patients fill these forms out before they even come to see us. And here by us it's called a health quest form, but there's many different forms, and it basically just gets at the history of the patient and trying to figure out if they have any conditions, baseline conditions, or previous medical problems that can increase the risk for surgery. So we'll get at kidney problems, heart problems, exercise intolerance, histories of CVAs, and respiratory conditions. And for any patient that really has a completely negative screening questionnaire, usually there's no other more extensive testing needed. So that's an important tool to start with. For patients who have cardiac risks, there's guidelines from the American Heart Association about how to manage these patients. And again, the goal is to identify patients that are at increased risk for major adverse cardiac events, and then select these patients for an evaluation. But again, only do it if it will actually change the management. And for those patients who are at risk, treat those patients before surgery to reduce the risk, and then also post-operatively monitor them more closely for potential post-op complications. So the bad news about this is that for patients who have perioperative cardiac complications, the hospital stay gets more complicated, and the length of stay is longer by 11 days. More importantly, these patients who have a perioperative MI have a 15 to 25% of in-hospital mortality. And patients with cardiac arrest after non-cardiac surgery have a 65% risk of hospital mortality rate. So major cardiac complications can be quite serious. The good news is that in non-emergent surgery, the absolute rates of cardiac death and MIs are extremely small. So in one study with an unselected population, so not at increased risk, the observed rates were extremely low, with cardiac death of only 0.3%, MIs of 1.1%, and arrests 0.4%. So how do we figure out which patients are at risk for major cardiac events? And the most commonly used risk stratification for that is the Lee Revised Cardiac Risk Index, most commonly just known as the RCRI. And that was published back in 1999 and has been widely used since then. And it's relatively simple. There's 6 independent predictors. One is the type of surgery, which is important, and high risk is considered vascular surgery or open intraperitoneal or intrathoracic surgeries. Then in terms of the history, there's history of ischemic heart disease is important, heart failure, history of stroke, diabetes mellitus requiring treatment with insulin, or chronic kidney disease with a preoperative serum creatinine greater than 2. So each one of these risk factors adds 1 point to the cardiac risk index. And when you sum these points up, then you can come up with a prediction for major cardiac complications. And if you know risk factors, the chance of a major cardiac event is 0.4%, then 1%, 2.4%, and in the highest group, for 3 or more risk factors, it's 5.4%. And this depicts it for different types of procedures with a stepwise increase for 1, 2, 3, and 4 risk factors in terms of the risk of major cardiac complications postoperatively. And usually when we have a patient evaluated by the medical service or by cardiology, this is the most commonly used risk index to determine what the risk for postoperative major cardiac complications are. There are other risks stratification scores available. We're all very familiar with the ASA, or the American Society of Anesthesiologists Physical Status Score. It's a very rough estimate at risk, with 1 being a normal healthy patient, 2 being patients with mild systemic disease, 3 is patients with severe systemic disease, 4 are patients with disease that's a constant threat to life, 5 are really the sickest patients who are not expected to survive without an operation, and then 6 is organ harvest operations. And it's a very commonly used score. It's not very granular, but it's used commonly also in research. The Charleston Comorbidity Index is also mostly used in research purposes. The POSSUM score has recently been validated to be a very good predictor. The Apache score is used more commonly in critical care settings. And one score that I'll be talking about a little bit more detail now is the ACS-NSQIP risk calculator, which is based on complications from the NSQIP database and is a very well validated risk calculator. Now, all these different scores differ in how well they discriminate between different risk factors and how reliable they are. And again, I'll talk here about the ACS-NSQIP risk calculator, which was described by Bill Moria et al. In 2013. And the goal of the calculator is to provide accurate and patient-specific risk information to allow both for surgical decision-making and informed consent. There are 20 different predictors that it uses. Among them is a different risk calculator, which is the risk score, which is the ASA class, and also the planned procedure, and that's entered with the CPT code to predict the chance that the patients will have different outcomes, and it really gives granular detail about 15 different possible outcomes within 30 days. And as I said, it was built using data collected from the NSQIP database, using 3.8 million different operations from 740 different hospitals. So a huge data source with a very broadly applicable range of different hospitals. And it's shown to have excellent performance for mortality and for morbidity. It's more comprehensive, but also more cumbersome than many of the other risk calculators. In addition, one other limitation is that this calculator has not been externally validated yet. So this is what it looks like when you go to the ACS-NSQIP calculator website, and there are many different fields to fill out. Like I said, it's a little bit cumbersome, but most of this information should be readily available. And then once you put in all the information and you continue, the calculator gives you a risk score for different outcomes. And as you can see here, it will tell you how much higher than average the risk for this specific patient is. And another option that's there down here in the right lower corner is where the surgeon can adjust the risk score when just based on, without any factors that go into the actual calculation, but however the surgeon has the impression that this patient is at above risk than normal to adjust it, and then the calculator will take that into consideration as well. So it's like I said, it's a very granular and very detailed risk calculation, and while it's not necessarily there for specific intervention for the patient, it does allow a very detailed discussion with the patient and the family about potential postoperative complications, and is very useful with informed consent and for patients who are considering surgery and have other alternatives. So once we do calculate a risk, how do we manage these patients? What should we do about them? So for low-risk patients, so when we use the RCRI index, so when we have patients that are estimated to be at risk of less than 1%, those are patients that are considered low risk and you don't need to do any further cardiovascular testing. However, patients that are higher risk, so those patients who have more than one risk factor, those are the patients that may require additional cardiovascular evaluation. And this would either be stress testing or echocardiography or consultation with a cardiologist. And many studies of patients that are not at low risk have shown that performing some form of stress testing can further stratify the risk of an adverse perioperative event. However, unfortunately, no study has really shown that interventions performed based on these results really improves outcomes. So, it's a consideration to take here that yes, we can do the testing to better stratify patients, but as of now, there haven't been any great studies showing that these tests really lead to much better outcomes. Now, in patients, even when they are at higher risk, if they can perform greater than 4 METs of activity, and I'll talk about that in a minute, no further testing is recommended. However, if the functional capacity is lower than 4 METs or unknown, additional testing may be indicated if it will influence perioperative care. So what exactly is the 4 METs of activity? So METs stand for metabolic equivalence, and it's defined as 3.5 mils of oxygen uptake per kilogram per minute, which is the resting oxygen uptake in a sitting position. So that's 1 MET. So when you see a patient, a patient that can take care of himself, eat, dress, use the toilet, that's a patient who has 1 MET. Now, a patient that can walk up a flight of steps or a hill or walk on level ground at 3, so a very brisk walk, those are 4 MET. So a patient, even if they have cardiac risk factors, if they can walk up a flight of steps without getting extremely winded, or they can briskly walk at level ground, those are patients that usually don't need any further testing. Similarly, greater than 4 METs is heavy work around the house, such as scrubbing or climbing 2 flights of stairs. And then 10 METs are people who can exercise, swimming, running, football, etc. So that's an important assessment that all patients before surgery should have, and that can be self-reported as well to see what this patient's functional baseline is. Now, for those patients who exercise tolerance is less than 4 METs and have more than 1 risk factor, those are the patients where you want to send them for cardiac testing. And the most really telling test is stress testing with either exercise or pharmacologic stress testing with imaging at the same time. And this has been studied in patients scheduled to undergo cardiac surgery, non-cardiac surgery, and there's been a clear relationship between the degree of myocardial ischemia found during stress test and prognosis. Again, unfortunately, there's no strong evidence yet that prophylactic revascularization improves outcomes. In addition, resting echocardiography has not been shown really to have any great value in terms of assessing preoperative risk. However, if there is another indication, such as a patient with a murmur where you want to evaluate valve function, or in a patient at risk for congestive heart failure or dyspnea of unknown cause, the echocardiogram does have value. Now, the presence of significant left ventricular systolic dysfunction or severe valvular heart disease, such as aortic stenosis, that's been known to be associated with worse outcomes, and that's an important thing to determine with echocardiography. So, to summarize this algorithm to preoperative cardiac risk assessment, so initially you want to screen the patient with an history and physical, or using one of the screening questionnaire like I showed before. So patients who have any known risk factors, you then get to this first branching point. And if it's an emergency, obviously there's not much preoperative risk stratification that you can do. And then you have to proceed with surgery. Patients with acute coronary syndrome, obviously that will take you down a different route. And that's a patient you will first have to address that. Now, a patient who is not having an acute coronary syndrome, that's the patient then where you want to start with the assessment using the RCRI. And in those patients that are low risk, so less than 1%, you don't need to do any further testing and you can proceed with surgery. On the other hand, patients at elevated risk, that's when you want to assess their functional capacity. And those are the patients when you know that they're greater than 4 METs, meaning they can walk briskly on level ground or walk up a flight of stairs. Those are the patients that are considered to have moderate or good functional capacity. And again, in those patients, you don't need any further testing. On the other hand, with patients when you don't know their functional status, meaning like, for example, they have orthopedic issues that they can't walk, or they're known to not be able to achieve 4 METs, those are the patients that you do further testing. And that's where you want to do a pharmacologic stress test. And then if it's abnormal, those are the patients you'll usually have seen by cardiology and potentially undergo cardiac catheterization. On the other hand, if the pharmacologic stress test is normal, you can proceed with surgery. So that's the algorithm that sort of explains how to proceed in terms of cardiac risk stratification. One group to keep in mind are high-risk cardiac patients, and those are patients who had a recent MI within 60 days, or unstable angina, decompensated heart failure, high-grade arrhythmias, or significant valvular heart disease, like I discussed before, especially aortic stenosis. Those are patients you really want to discuss with a cardiologist for further evaluation and management. However, in emergency surgery, when these risk indices are not accurate, and then you just have to weigh risks and benefits. And usually in patients needing emergency surgery, the benefits of surgery usually outweigh the risks. You can still counsel the patient, and in terms of post-op management, those patients at higher risk should be more closely watched. So to summarize, in terms of preoperative risk stratifications, all patients scheduled to undergo surgery should have a preoperative risk assessment, and that should have at least a history and physical or a screening questionnaire. And then consider the type of the proposed surgery, the risk of the proposed surgery, and the functional status of the patient. The revised cardiac risk index then can be used to assess the need for any further cardiac testing. In general, any patient with a cardiovascular history should have an EKG so that you have a baseline. And then if the RCRI is greater than 1 and MET is less than 4, meaning the functional capacity is less than 4, those are the patients that you want to send for a stress test. And then, as we saw, the ACS-NIST script calculator is an excellent tool for very detailed patient counseling in terms of risks for postoperative complications. So moving on then to enhanced recovery after surgery. So it's also known as ERP, or enhanced recovery pathways, or enhanced recovery protocols, or fast-track surgery. So it was pioneered by colorectal surgeons, but is now widely used across multiple surgical disciplines around the world. And what it is, it's a standardized, multimodal, and multidisciplinary perioperative care path that utilizes evidence-based interventions to minimize the patient's stress response to surgery and thereby accelerate recovery. And it really has become the standard of care with best practice bundled interventions that span the entire perioperative period. So the goal of enhanced recovery is to minimize the stress response to surgery. Anytime we do surgery, it induces physiologic stress, but if we can have interventions in place that minimize the stress, the recovery is faster and the patient returns faster to his baseline functional status. And like I said, it was popularized by a colorectal surgeon, a Danish colorectal surgeon, Dr. Henrik Kielet, back in the 1990s. It quickly made it over to the United States, and here at the Cleveland Clinic, it was first described back in 2001. And Dr. Delaney back then showed that even in very complicated patients, so these were patients with IBD, colorectal cancer, intracutaneous fistulas, implementing an enhanced recovery pathway, or at the time it was called controlled rehabilitation and early ambulation and diet, really achieved excellent outcomes in terms of short hospital stays with low readmissions and complications. So enhanced recovery has been around for a long time. However, recently the number of publications on this topic have gone up in a incremental and rapid fashion, and it's a very hot topic of research, and there have been many improvements and fine-tuning of enhanced recovery pathways since its inception. So what exactly are these interventions part of an enhanced recovery pathway? So the main thing is that care is no longer based on traditional surgical dogma, but really based on evidence and evidence-based interventions. And so when in the past patients was told to be fasting after midnight, nowadays patients are allowed to drink up to 2 hours before surgery, and we're implementing carb loading, immunonutrition, and other nutritional intervention to minimize the effects of malnourishment. In the past, open surgery was routine. Nowadays, we do laparoscopy with its improved short-term outcomes. In the past, patients received large volume IV fluids. Nowadays, as part of an enhanced recovery pathway, we'll be talking about how you can more judiciously give IV fluids. Narcotic analgesia used to be the backbone of all postoperative pain control, and nowadays we try to treat patients within an enhanced recovery pathway with multimodality and narcotic sparing. Similarly, NG tubes have fallen out of favor in enhanced recovery pathways, and in fact we try to initiate immediate diets. When in the past bed rest was used, now we use early and frequent ambulation. We try to avoid drains. And importantly, really the entire care is centered around the patient with engagement and education of the patient to make them an active part of the process. And those all have been shown to have important implications on the patient's recovery. So again, it's a standardized multimodal perioperative care path that spans the entire operative care phase, including a preoperative phase, an intraoperative phase, and a postoperative phase. Now, I'll talk about that in further detail. This is just a sample shot of what our US pathway looks like at the Cleveland Clinic for colorectal surgery. And again, we divided within phases. We have a preoperative phase, which has its own different sections, an intraoperative phase, a postoperative phase. And again, the goal is to have evidence-based intervention for each one of these time periods to improve patient outcomes. And I'll be talking about these different phases and interventions in detail now. So when we talk about the pre-op phase, education is an important factor. And when we talk about education and enhanced recovery pathways, really it's not just education in terms of instructions, because we've always been doing that, instructing the patient what to do, but a lot of the enhanced recovery part of it is conditioning of expectations. And it's important to counsel the patient that he's an integral part of the process and an active participant in his or her own enhanced recovery process, meaning that the patient also has agency and control over how they will do. And managing expectations is really critical. So besides just telling the patient, explaining the disease, the plan of the surgery, the risks and benefits associated with the surgery, the patient should also be informed about his postoperative expectations, including daily goals and milestones regarding pain management, physical activity, and diet. And what's really important in terms of being able to get the patient recovered and ready to leave the hospital in a timely fashion is for the patient to know what the criteria for hospital discharge are, and set realistic expectations so the patient should know how soon after surgery they'll be able to go home, which will also help with logistics and can help improve outcomes. It's been shown that giving the patient detailed instructions, including checklists and pictures, can be really helpful in terms of the patient's compliance with these instructions. Like I said, expectations regarding post-op activity should also be included in any educational material, and most importantly, setting realistic expectations regarding post-operative pain management. And it's important to tell the patient that there will be pain after surgery, and however, that pain will be addressed. So instead of telling the patient that we'll make sure that you won't have any pain, it's important to tell the patient there'll be some pain and we'll do different interventions to get the pain controlled. However, it's normal to expect some pain, and setting this expectation can have a dramatic effect on patient satisfaction and outcomes as well. And again, it's important to discuss discharge criteria, expected length of stay, and help the patient prepare for post-discharge. If the patient has a stoma, starting with the education for post-operative stoma care already in the preoperative phase can really help set the stage and help the patient prepare for that, which will help with reducing readmissions following discharge. In terms of optimization, there are different factors that we want to optimize in patients, such as anemia, diabetes, malnutrition, obesity, smoking, alcohol and drug abuse, and I will also be talking about prehabilitation, which is the goal is to optimize preoperative functional status. So specifically anemia, there's obviously a high incidence of anemia and iron deficiency among patients undergoing abdominal pelvic surgery for malignancies or chronic conditions such as inflammatory bowel disease. And whenever there's a patient who's preoperative and there's a history or suspicion for anemia, the cause for anemia should be investigated. And in patients that are anemic, we routinely get a CBC iron studies, and in older patients also check for B12 and folate, or if we have any suspicion for malabsorption. And in patients who are planned for elective surgery, there's a room and time for optimization with either oral or IV oral supplementation based on severity and absorption ability. And there's data that has shown that giving patients iron supplementation before surgery can reduce the need for transfusions, and that's important. However, in patients who have severe anemia preoperatively with a hemoglobin that's less than 6 or a hemoglobin that's between 6 and 8 with significant comorbid conditions and or expected large blood loss during surgery, those are patients that you might want to consider preoperative transfusing. So for patients with diabetes, it's now well established that perioperative hyperglycemia is a predictor of post-op infections and mortality. And these infections are independent of the patient just being a diabetic and more related to perioperative hyperglycemia with its resultant impaired leukocyte function, chemotaxis, and phagocytic activity, which are all important functions to reduce infections. It's therefore it can be helpful to measure a hemoglobin A1C preoperatively, as that will identify patients that are at risk for poor glycemic control and therefore allow for preoperative interventions. On the day of surgery, diabetics should discontinue oral hyperglycemics due to risk of hypoglycemia when NPO, and sulfonylureas have been associated with risk of myocardial ischemia, and those should be discontinued. Similarly, metformin has been shown to have some risk for lactic acidosis, which we don't want to continue in the perioperative phase. And the goal of care for diabetics and non-diabetics really is tight perioperative glucose control using an insulin sliding scale, and in patients who need on top of it a basal long-acting insulin that can be used as well to prevent large fluctuations in perioperative glucose. Prehabilitation is a topic that's really become a very active area of research and of interventions over the last several years. And what prehabilitation is, it's a multidisciplinary intervention that aims at using the preoperative period to attenuate disease and surgery-related functional decline and its consequences. And really to summarize what prehabilitation is that when we counsel patients before surgery, we frequently tell them that major surgery is like running a marathon. And just like a marathon requires training, and you get better results when you train before a marathon, similarly, if you're undergoing major surgery, preparing for it will result in better outcomes. And multimodal prehabilitation can include exercise training, nutritional therapy, psychological interventions, and inspiratory muscle training with an incentive spirometer. And the potential benefits are accelerated return to baseline function, reduced post-operative morbidity, decreased length of stay, improved quality of life, and in patients with malignancy, early initiations of adjuvant chemotherapy. So when we look back at the enhanced recovery graph of the functional status, enhanced recovery after surgery, the goal is to reduce the stress of surgery and thereby get them back to their functional status faster. The idea of prehabilitation is to increase their baseline functional status, and thereby when they undergo surgery, really the stress of surgery will not reduce their functional status as much as if the functional status was lower before. And that should thereby decrease the risk for morbidity at the time of surgery when the stress reduces the overall physiologic reserve. So what are the risk factors that really influence the patient's functional capacity? And there's frailty, malnutrition, anemia, sarcopenia, neoadjuvant chemoradiotherapy, and psychologic conditions that all play a role in the functional capacity of the patient. So frailty is defined as a decreased physiologic reserve and multi-system impairment separate from the normal aging process, meaning not every old person is frail, and patients who are young can also be frail. So frailty has been shown to be associated with postoperative complications, length of stay, and discharge disposition. And there are many different ways of how to screen for frailty, and we spoke about the metabolic equivalence, and patients with a metabolic equivalent less than 4, that's a marker of frailty. There are more specific indices for frailty, such as the modified frailty index, which takes different comorbidities into account to come up with a score. And then there's also a more simple pictorial view of frailty score from Canada, which is similar to the stages of human development, really, where you can really, just by looking at the patient and sort of judging what their functional capacities, come up with a frailty score. And I think most of us can recognize frailty when we see it, but all these different scores allow us to monitor it and follow it in sequence. There's more specific assessments of frailty with different tests, and really the gold standard is the cardiopulmonary exercise testing, which measures the VO2 max, and that's a pretty intense exercise test that's also used in athletes, and that gives you really the gold standard of telling you how good the baseline patient's functional status is. A more easy test is the 6-minute walk test, which has the patient walk for 6 minutes and measures the distance. And there's been shown good correlation between the 6-minute walk test and CPET in terms of post-op recovery. And a distance of less than 400 meters in 6-minute walk test has been shown to be an indicator of poor surgical outcomes. Other tests and assessments that are used to measure frailty are a timed up and go test and a grip strength test. And these are useful in patients for assessment, and also if you have a patient on a prehabilitation program, you can then follow the patient to see if they've made any improvements. Another marker of frailty is sarcopenia, and what that means is loss of skeletal muscle and strength, and it's associated with frailty and poor outcomes in both surgical and non-surgical patients. And what it is, it's an analytic or morphometric processing of imaging studies, traditionally CT scans, but more recently people have used ultrasound as well, that can quantify the muscle mass, usually using the psoas muscle. And there have been studies that have really shown that the degree of of sarcopenia correlates very well with hospital utilization and complications. And as you can see from this picture down here of the CT scans, you have patients with very similar comorbidities. However, one patient has a very attenuated psoas muscle, a sign of sarcopenia, whereas the other patient does not have any sarcopenia. And like I said, it's been shown that sarcopenia itself is a risk factor for perioperative outcomes. In terms of the interventions to improve upon frailty, the main intervention is exercise training. And there are many different ways of how exercise training has been described and can be done. There's different types of exercises, such as aerobic exercise, and then there's different degrees of intensity. We have moderate intensity versus high intensity. And importantly, in terms of implementation of exercise, there's unsupervised, where the patient does it at home, versus supervised, where the patient comes in once or multiple times a week and performs supervised exercise within a medical setting. And somewhere in between would be where the patient does it unsupervised but wears a Fitbit or other fitness tracking device that can then communicate with the medical team, and the progress can be monitored. In terms of the goal, really we ask our patients to go along the CDC guidelines of performing 150 to 300 minutes a week of moderate intensity, or 75 to 150 minutes a week of vigorous intensity. So that's quite a steep curve there for patients who are a bit frail at baseline. When we're using a pedometer, the recommendation is to increase the daily steps by 300 to 500 each week, with the ultimate goal being 10,000 steps a day. And obviously not every patient will be able to achieve these goals. However, it is good to set some goals and to personalize them based on the patient's capacity at the time. So these are some guidelines. However, every patient will be different, and the goals to be achieved will be different based on the patient. And there have been many studies, fairly large body of literature on the efficacy of exercise interventions, and the data is mixed, and it's difficult to really compare between studies because the interventions are different and the outcome studied is different, with some studies looking at a 6-minute walk test, other studies looking only on perioperative outcomes as the primary outcome. And like you can see here, the interventions really are very different in terms of what exercise is done, if it's supervised or unsupervised, and how often a week. And many of these studies have actually not shown any difference in postoperative complications, but some studies did show a decrease in severe postoperative complications and also decreased costs. And one of these studies that I just wanted to quickly highlight here is a very recent study that was published last year in the Annals of Surgery. And this was a very rigorous prehabilitation program, and they focused on high-risk patients. So these were older patients, ASA 3 or 4, that were undergoing major abdominal surgery. And all patients underwent standard preoperative recommendations for physical activity, nutrition, counseling, etc. However, the prehab group underwent a motivational interview and assessment by physical therapy, and then a personalized program for daily physical activity, including a supervised high-intensity exercise training that was 2 to 3 times a week using a cycle ergometer for 45 minutes. So a very intense prehabilitation program in these patients. And the results and conclusion of the study showed that in these high-risk patients, performing this personalized prehabilitation program that includes supervised high-intensity training, the patients achieved increased aerobic capacity and showed a significant decrease in overall complications, postoperative cardiovascular complications, and postoperative ileus. So, to summarize this, it's difficult to draw consistent conclusions from the published data due to the heterogeneous study's design and different interventions. However, it seems like the supervised and high-intensity programs will show the greatest benefit in high-risk patients, but further high-quality studies are needed to determine the best pragmatic interventions that can lead to improved outcomes. Moving on to nutritional optimization. So we all know that malnutrition is a common problem among oncologic surgical patients and other chronic conditions. It's often under-recognized and undertreated. It's associated with high risk of surgical complications, prolonged length of stay, delay of adjuvant therapy in cancer patients, mortality, and costs. And there's a strong rationale for proactive nutritional interventions. However, only 1 in 5 patients receive any dietary intervention at all. So how do we screen for malnutrition? So very easy way of screening is just looking at a BMI, recent weight loss, and albumin level. Now, albumin, it's not a great predictor, but it has been established to show correlation with postoperative outcomes. The patient-generated subjective global assessment, it's a 4 patient-generated historical components, and that's been shown to predict morbidity, mortality, and quality of your life. And it really can be used to screen, assess, and monitor longitudinally. A similar screening tool is the Nutritional Risk Screening Tool of 2002, which can stratify patients as low versus high risk, and it uses the BMI, weight loss over the last 3 months, and the dietary intake and disease severity to screen patients for malnutrition. And those are all tools that help us assess patients who would benefit from an intervention. And what is the intervention that we can recommend then? So ideally, patients would then get education by a registered dietitian with the goal of meeting the energy requirement, but that needs to account for whatever hypermetabolic state the patient is currently in and whatever exercise expenditure the patient has. We recommend patients to have a high-protein diet before surgery, with a daily protein intake of 1.5 grams per kilogram of their ideal body weight. And when patients take that from diet, we recommend to get the protein from fish, chicken, or egg. And ideally, though, to ensure compliance, it's easiest really to obtain that with oral supplements using whey or essential amino acid-based supplements. And in terms of meal, we recommend a balanced meal, including appropriate ratio of starches, protein, and vegetables. However, when severe nutritional risk is identified, surgery should be delayed if possible to correct nutritional deficits for at least 7 days pre-op. And in patients who are unable to meet caloric intake by mouth, it has been shown that a 7-day or longer of TPN can help reduce complications after surgery. More recently, there's been data showing the benefits of immunonutrition. And immunonutrition is nutrition that's rich in protein with the addition of arginine, glutamine, and citrulline, and omega-3 fatty acids, and nucleotides. And there's been both theoretical and data now that shows that immunonutrition can reduce postoperative complications following major abdominal surgery. And there are many different products available that have similar components in terms of immunonutrition. There was a recent meta-analysis that included 83 randomized controlled trials of immunonutrition. Again, the design was somewhat different between studies, but overall there seemed to be a reduction in complications, specifically infectious complications, and a shorter hospital stay. Now, there was a high risk of bias in these studies, and of note, those studies that were not sponsored by industry, the benefit was less. And more importantly, though, many of these studies were not done within an enhanced recovery pathway or in minimally invasive surgery patients. So it is conceivable that in patients that are already in an enhanced recovery pathway, the benefits of immunonutrition would be not as pronounced. Furthermore, there's very limited data on real-world implementation and compliance with these supplements. In terms of psychological prehabilitation, it's understandable that there's a high rate of anxiety and stress among surgical patients, and that's been shown to have a negative impact on postoperative recovery. And there's been a recent focus on cognitive behavioral interventions with the goal of reducing anxiety symptoms and promoting active coping mechanisms. And there's data that's shown that it really helps with patients' satisfaction and with recovery process. And this prehabilitation can be done with a single psychosocial visit for most patients, where the patient discusses their beliefs about disease and surgery and allows for reframing of the thoughts to a more positive interpretation. Relaxation and imagery techniques have been shown to help reduce pain perception and need for opioids, and promoting healthy sleep habits has also been shown to help in the recovery process. So just to summarize what prehabilitation really is, it's a multimodal intervention aimed at improving patients' baseline functional status. And while it's difficult to compare studies due to very variable protocols and outcomes assessed, there is evidence that showed that improved exercise tolerance can lead to decreased complications and hospital costs. And these benefits are likely more pronounced in high-risk patients, and these are probably the patients that we should select for a more personalized and supervised prehabilitation program. And a pragmatic approach to a prehabilitation balances the risks and benefits and the logistics and costs of various prehabilitation interventions, meaning, again, selecting high-risk patients for a more personalized prehabilitation process, while at the same time keeping all patients involved. We have a more universal prehabilitation process that is not as cost and effort intensive. So when we get closer to the day of surgery, the enhanced recovery pathways have different guidelines for preoperative bowel preparation, and in the past, ERAS guidelines actually recommended against bowel preparation, and in many centers, especially in Europe, this is still the recommendation to omit bowel preparation. And that's because there have been randomized controlled trials that have shown that there's no benefit in terms of postoperative outcomes with a mechanical bowel preparation. However, there have been more recent data that show that when mechanical bowel preparation is combined with all antibiotic preparation, that there is a benefit in terms of reducing surgical site infections and C. diff. And therefore, current American guidelines recommend the routine administration of mechanical bowel prep in combination with oral antibiotic preparation as part of preventative surgical site infection bundle in colorectal surgery. And that goes right into my next slide here, which is about surgical site infection prevention. And it's really a bundle that's been shown to have the best effect in terms of reducing surgical site infections. So each one of these different components of the bundle have some data supporting them, but the biggest effect is when these are all bundled together as an SSI prevention bundle. And there have been meta-analyses that have shown really a significant decrease in surgical site infection in programs that use a bundle. And this bundle includes chlorhexidine shower either the day before, the day of surgery, as discussed, a mechanical bowel prep of all antibiotics, including prophylactic IV antibiotics within 1 hour before incision, and it's important to use the right antibiotics for the right surgery. Then prepping the surgical field with a chlorhexidine-based prep. Using wound protectors has been shown to reduce infections. Changing gloves and instruments before fascial closure is important, especially for contaminated cases. Having a dedicated wound closure tray, and then keeping the patient normothermic and euglycemic, and limiting operating room traffic. All these interventions as a bundle have been shown to reduce surgical site infections. Another component of the enhanced recovery pathway is limiting post-operative nausea and vomiting using prophylaxis. And the incidence of post-operative nausea vomiting is as high as 30% in all comers, and in patients with documented risk, it can be as high as 80%. It's been shown that post-operative nausea and vomiting increases hospital costs and significantly reduces patient satisfaction. And therefore, current guidelines support a preoperative risk assessment of all patients undergoing anesthesia and subsequent tailored multimodal therapy to prevent and treat post-operative nausea and vomiting. And this here is a table using a risk-adjusted approach to prophylaxis, where each one of these risk factors, such as female gender, non-smoker, history of post-operative nausea, vomiting, the need for post-operative opioids, are all included as risk factors. And then based on these risk factors, you can come up with a score. And based on each score, you can add different interventions to reduce post-operative nausea and vomiting. With for the highest risk patients, you want to include ondansetron or Zofran, Decadron, and propofol infusion and scopolamine in patches. And with the propofol infusion, it's also important to limit the volatile anesthetics and what's known as total intravenous anesthesia as for the highest risk patients for postoperative nausea and vomiting. Going together with that is also multimodal opioid sparing analgesia, and I include that in the pre-op phase. However, it really spans the entire operative phase, where you want to start with multimodal analgesia in the preoperative phase, since it has been shown that preemptive analgesia is more effective, and then continue it throughout the operative care period. And it's been shown that minimizing opioids is associated with earlier return of bowel function and shorter length of stay. And different ways to reduce opioid intake is using multimodal analgesia with NSAIDs, acetaminophen, as these have been shown to reduce systemic opioid consumption. There's less data, but still a common component in many enhanced recovery pathways is using gabapentin as another adjunct to pain control. There's some data that concerns NSAIDs in terms of anastomotic leaks, and the data is mostly inconclusive at this point. While there might be a mildly increased risk of anastomotic leaks, there have been multiple studies that have shown that there really is no increased risk with NSAIDs. And at this point, most enhanced recovery guidelines will include NSAIDs as part of their pathway. There have been now several studies that have shown that TAP blocks, or transverse abdominis plane blocks, can decrease the need for opioids, improve pain scores, especially in laparoscopic colorectal surgery. And the TAP block entails injection of a local anesthetic into the transverse abdominis plane, which leads to local anesthesia of the abdominal wall, and thereby reduce pain scores and the need for opioids. In the past, thoracic epidurals were a very important component of enhanced recovery pathways. However, with the advent of laparoscopic surgery, it's been shown now that thoracic epidurals really don't have much of a role anymore in laparoscopic cases, because they've been shown actually to increase length of stay in patients undergoing laparoscopic surgery. However, there still may be a role for epidurals in patients undergoing open surgery or patients who are on chronic opioids. All right, so moving on to the intraoperative phase of care, the surgical approach is very important within an enhanced recovery pathway. And it's now well documented that laparoscopic surgery is associated with improved outcomes, especially quicker return of bowel function, less blood loss, less postoperative pain, and shorter hospital length of stay. And therefore, whenever appropriate and the expertise is available, a minimally invasive surgical approach should be used. there's been some question about the benefits of laparoscopic surgery within an enhanced recovery pathway, or on the flip side, the benefits of an enhanced recovery pathway in laparoscopic surgery. And there was a well-designed randomized controlled trial to address this question, and what it showed is that the patients that did the very best were those patients who were both undergoing minimally invasive surgery and part of an enhanced recovery pathway. So meaning that both are independently beneficial to the patient outcomes. In addition, in terms of the surgical approach and what we do at the time of surgery, we want to reduce the need for intra-abdominal drains, and there's really, in colorectal surgery, there's been now very high-level evidence showing that there's no benefit of keeping abdominal drains in place, and prophylactic nasogastric tubes have been mostly abandoned at this point, and especially in mid or hindgut surgery, there really is no benefit to keeping routine NG tubes in place. In fact, it has been shown that they can delay return of bowel function in some studies. Intraoperative fluid management is a very hot topic again, and there are many different terms that are being used in terms of how fluid should be administered at the times of surgery. There's liberal, restrictive, judicious, balanced, euvolemic, and goal-directed fluid therapy. And really, this started as back in the early 2000s when the first studies came out showing that excessive intravenous fluids can really harm patients. And this was a study published back in 2003 showing that there was really a dose response curve where patients that received more fluids within the first 48 hours of surgery had a higher frequency of complications. However, more recently, there was an article just published last year in the New England Journal of Medicine where there was a very well-designed, multi-centered, randomized controlled trial where they showed that in patients at increased risk for complications, a restrictive fluid regimen was not associated with a higher rate of disability-free survival than a liberal fluid regimen. And in fact, the patients in the restrictive regimen were associated with a higher rate of acute kidney injury. So again, there's debate now about what the optimal amount of fluids are that patients should be receiving at the time of surgery. And what we do know is that insensible fluid losses have been in the past overestimated. And even in patients that undergo open surgery where the bowel is fully exteriorized, insensible fluid losses do not exceed more than 1 cc per kilogram per hour. And the other important factor to keep in mind is that the response of the patient to surgical trauma leads to a physiologic reduction of urine output. So low urine output at the time of surgery in itself should not lead us to give the patient large amount of IV fluids, since it is a normal physiologic response to the stress of surgery. There have been recently an attempt to better quantify how much fluid should be given to the patient. The concept of goal-directed fluid therapy was started, and that bases intravenous fluid administrations on more objective measures of hypervolemia, and that can be done with different types of monitors. Most of them can be non-invasive, such as esophageal probes, and they can measure cardiac output, stroke volumes, oxygen delivery, or pulse pressure variation. And the idea of goal-directed fluid therapy is to only give as much fluid as we think will be effective in terms of end organ perfusion. And there have been several meta-analyses of randomized controlled trials that have shown that goal-directed fluid therapy reduces postoperative morbidity and length of hospital stay, especially in high-risk patients. However, it's been also shown that in patients that are treated within an enhanced recovery pathway, those advancements in perioperative care that are part of the enhanced recovery pathway seem to offset benefits of goal-directed fluid therapy, meaning that patients who are already on an enhanced recovery pathway with all the other components in place, the extra addition of goal-directed fluid therapy does not seem to make that big of a difference. So when looking at multiple different publications on the topic of intraop IV fluids. This was done in this meta-analysis back in 2010. It seems that when comparing these studies, really the goal should be achieving normovolemia. Because when you underhydrate patients, you do risk kidney injury, and when you overhydrate patients or do fluid overload, you have the downsides of pulmonary complications, ileus, prolonged length of stay. So it's really about hitting that middle of the road of normovolemia, otherwise known as the Goldilocks principle, where you want to have it really just right. And that should be the goal at the time of fluid administrations. You want to make sure you give the patient enough fluid, but really avoid fluid overload. When we move on to the post-operative phase, it's been well established that bed rest is bad for the patient, and prolonged immobility leads to skeletal muscle loss, weakness, atelectasis, insulin resistance, and blood clots. And the deconditioning that's associated with bed rest can be reduced with physical activity. It's a key component to get patients out of bed early on, and it's in line with the goals of supporting the early reestablishment of normal function. There have been some studies that have tried to show the benefits of specific mobilization protocols. However, there's no good data to support one specific method of mobilization over another. However, the goal should be to get the patients out of bed early on, and that can accelerate their recovery. In terms of diet and ileus prevention, so there have been multiple randomized controlled trials and meta-analyses that have now shown that early feeding, meaning within 24 hours of surgery, can accelerate GI recovery and thereby decreases the hospital length of stay in colorectal surgery, which is known to have a high incidence of postoperative ileus. In fact, even the rate of complications and mortality was also decreased with early feeding. And therefore, the recommendation is that patients should be offered a solid diet within 24 hours of surgery, as long as there's no nausea, vomiting, or abdominal distension. There have been a number of trials also that suggested that chewing gum can help to early return of bowel function and a reduced length of stay. However, a more recent large randomized control trial out of Britain showed really no difference in return of bowel function or length of stay. That being said, with gum chewing being a safe and cheap and easy intervention, it is something we routinely recommend to our patients to do. A more expensive intervention, a significantly more expensive intervention, is the use of alvimapan. And alvimapan is a peripherally acting mu opioid receptor antagonist, meaning it acts in the intestinal tract to counteract the effects of both endogenous and administered opioids to reduce the incidence of ileus. And there have been several randomized controlled trials that have shown that in patients undergoing intestinal resections or primary anastomosis, it can reduce the hospital length of stay by about 1 day. And therefore, it is a part of many enhanced recovery pathways to include alvimapan. However, there's limited data really that supports the role and the cost of alvimapan in laparoscopic surgery, and it might not be that beneficial in laparoscopic surgery due to the accelerated recovery that these patients have already. So from a value standpoint, the verdict is still out if alvimapan should be used in laparoscopic cases. However, for open cases, it is something we give our patients who undergo intestinal resections with a primary anastomosis. In terms of postoperative IV fluids and urinary catheters. Similar to intra-op IV fluids, it is important to avoid post-op fluid overload, and that would mean anything more than a 1 to 2 kilograms weight gain, as this has been shown to be associated with worse clinical outcomes. And therefore, in patients that tolerate oral liquids, IV fluid should be completely discontinued within 24 hours of surgery. Hypertension that's induced by epidural analgesia should not be managed by simple giving fluids, but rather by reducing the epidural infusion rate and with small dose of vasopressors, as long as the patient is known to be normovolemic. In terms of Foley's after surgery, it's well established that prolonged urinary catheterization is a significantly high risk for catheter-associated UTIs, and therefore, in the absence of specific contraindications such as bladder repairs or significant risk factors for urinary retentions, the Foley catheter should be removed within 24 hours of surgery or even in the operating room itself. So to summarize, enhanced recovery pathways are multimodal and interdisciplinary evidence-based perioperative approaches that result in standardization of patient care, thereby minimizing variability and maximizing efficiency and value. EAPs have evolved significantly since initially described to include multiple specific interventions throughout the whole healthcare episode, and well-designed EAPs result in a reduction in morbidity and decreased length of hospital stay without an increase in readmission rates. And the proven benefits seen with EAPs have therefore been established as this approach to perioperative care is the current gold standard of care. Thank you.